Okay, good afternoon, everyone. Thank you so much for joining us this afternoon for a webinar that we are hosting called Optimizing Your Breast Health Through COVID and Beyond. And this is a discussion and some Q&A with the clinical leadership from the Wisdom Study. So thanks everyone so much for joining. Some housekeeping, so format for today's session, all of the attendee microphones have been muted. The meeting will be recorded and posted to our YouTube channel for viewing later on. Please send us your questions via the Q&A function at the bottom of the Zoom screen. And we did receive some questions ahead of time as well, so we will ask those questions towards the end. And then throughout the webinar, we have some poll questions that we'd love for you to respond to, so that can help us guide some of the discussion topics on today's webinar. And afterwards, we will email you a short post-meeting survey for your feedback. Much of this is to understand what you might be interested in for the next webinar and what information you may be interested in hearing in the future. So today, what you'll learn, we'll discuss some important issues around breast health after the shelter in place, going into clinics and breast screenings and appointments, any changes in breast health that you should be aware of that may require immediate attention, and optimizing your breast health through screening and other strategies. We also have a discussion specifically on breast cancer risk genes and breast cancer risk overall, how genetics play a role in your overall risk for breast cancer, and then what the Wisdom Study is researching and how the study, we hope, will impact all women and benefit the benefits of participating. And at the end, we will wrap up with time for the Q&A. So it is my pleasure to introduce Dr. Laura Esserman, who is the director of the Carol Frank Buck Breast Care Center at UC San Francisco. She is the founder of the University of California-wide Athena Breast Health Network, as well as the I-SPY trials and the Wisdom Study. And in her spare time, she is a singer, songwriter, theater performer, mentor, mother, family person. The list goes on and on. Usually that spare time is in the wee hours of the morning. And then also I'd like to introduce Dr. Lisa Madlensky, who is a board-certified genetic counselor. She provides cancer risk assessment and genetic counseling for patients and their families at UC San Diego Health. And as part of that, she helps people investigate their family health history, navigate the genetic testing process, and understand the medical and psychological implications of genetic diseases. She is the proud mom of one. She's a Canadian. She's an avid cross-stitcher, and little known fact, she is a 5-time champ of the game show Bumper Stumpers. So I've had the pleasure of working with both Dr. Esserman and Dr. Madlensky over the last 8 years or so, and this should be a great session with lots of good information for everyone. So again, we encourage you to send in your questions. We'll have a good discussion towards the end of the session. So thanks so much for joining.
So thanks so much for the great introduction, Allison, and it's a pleasure to be with all of you virtually today. You know, life is changing because of COVID, but in some ways it allows us to reach out in different ways. We usually think about doing these kinds of events as in-person events, which doesn't necessarily fit into everyone's busy lives. And we are actually planning on doing at least one of these every month and taking on some of the interesting topics that we face and trying to think about how to advance the field. You know more about today. We're going to talk a little bit more about genetic risk. On another session, I'd like to really investigate does race and ethnicity apply to apply equally to people with breast cancer, and how can we get at that? What are the new ways we're thinking about for prevention? Some of the new studies on looking at dose finding, different doses of tamoxifen and side effects that are experienced. So that's actually, there's so many exciting topics that we can think about, and we're interested in what you want to hear about, and we want to talk a little bit about those issues as well. today I'm going to talk a little bit about breast health during COVID, and I want to talk a little bit about the Wisdom study and why once you're in it, your participation and your active engagement in the study is so essential, because that is what's going to determine whether we're able to successfully answer new questions and move the field forward. And I always say that, every day is an opportunity to try and do better than we were doing the day before. And by working together as a team, all of you who participate, all of us who are studying this, we can arrive at better answers and better options and better ways, to provide options for you to reduce your risk, to make sure that you are finding cancer at the earliest stage and treating it as successfully, not too much, not too little, but just the right amount. So as I'm sure all of you have experienced that, your screening schedules and visits may have changed due to the shelter in place. People who've had cancer, a lot of their treatments have changed, but in fact, many of the changes that have been kind of instituted nationally are things that we've been doing in our program for years, really trying to think about how to reorder the pieces of care so that you learn as much as possible, giving some of the systemic therapy first to try and figure out an early look at how well people are responding. And that is actually going to be something that we're going to be doing more of when we get to the prevention side of things. As far as screening, everyone had to shut down all their services for a few months, even the places that weren't hard hit with lots of cases. And the reason for that is, it's just a whole new day. People had to get their protocols for safely giving care to lots of people. They had to get those protocols in place. They have to make sure they had personal protective gear, they had rules, they understand it. They really, again, we've learned so much about the transmission. What we think of today is different than what we thought of in January. And certainly, we're a world away from the beginning of March. But for the most part, most centers are opening up their centers and they're doing it safely. If your routine cancer screening was delayed, don't be concerned, because almost everyone is open for screening now. The major centers are opening. I know at UCSF, for example, that we are opening the 13th of June for standard screening. And so it is safe to schedule your screening exams. People have put in place, careful ways of making sure people aren't coming in too many in the waiting room, and that they're making sure all the rooms are clean, et cetera. And if you recently have learned that you're very high risk because you've inherited a mutation that increases your risk for developing cancer, you can get your initial consult by video. That is often fine, and talk about what screening studies you might need so that if you come in, all of your care can be coordinated and done, and all the things that you need to do can be done efficiently in one visit. The kinds of things that require immediate attention, regardless of whether it's COVID or not, is if you find a new lump, regardless of whether you've had a recent mammogram, and this is so very important, you need to bring it to clinical attention, bring it to the attention of your primary care physician or to one of the breast centers. That's really critical. And don't think to yourself, if you really think it's new and different, we take that very seriously. But 50% of people still find their own breast cancers, and some of the more serious breast cancers really are more likely to show up between screens. So if you think there's been a significant change where the shape of your breast, or the size of your breast has changed, and there's a dimpling, something like that, call your doctor immediately. Know that we're here for you, and none of our programs have shut down. So we always say, what can you do for prevention and health promotion? Try to get outside every day, take a mask with you and use it. Try to get enough sleep. That, of course, does not apply to me, but eat healthy, not too much alcohol, and every day do something that makes you smile or brings you joy. So it's important to take mental health breaks. It's such an odd time, and I think it's so important to really connect, even if you're connecting by Zoom. We're humans and we need social interaction of some kind, and it's good that we have the technology to be able to reach out and contact people. So I'm going to go on to the issue of wisdom, and of course there certainly seems to be a lot of confusion about when to screen, and how often to screen. And now with COVID, when are the clinics open? When do they go? So things are really upside down. So I thought we would start with a poll question and ask, do you get routine, could everyone on the webinar tell us whether they get routine annual mammograms? Steph, how are they doing the poll?
The poll will launch automatically.
Okay, here's the poll for you guys. Everybody, we'll give you, this is da 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 da. Is that right? Okay.
And then they'll be tallied and the results will show up on the screen.
Okay, so we're waiting for everyone to fill it. And then right after this, we're going to have another question. So I hope you're on your computers and you're answering. Okay, can we show our results? Okay, so 65% of people are screening, 26% are not, about 9% say sometimes. That's actually pretty close to what our national averages are. So everyone's not screening. And so that's interesting. Okay, so let's go to our next question, which is it clear to all of you when to start getting mammograms and how often to go in for screening? And here's just a simple yes or no. Can we have our poll? There we go. Da 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 da. I think that's enough time. Let's see what we've got. So let's see, about 70% say yes and 30% say no. Okay, well, that's pretty interesting. I would say if you asked a physician poll, you would get maybe, you might get something similar, but I'll bet you if we drill down and ask people about the details, people would differ on what they think those guidelines are, because we know that there's lots of different camps and different factions in medicine. So I think that is, it's interesting, that here's the problem that the U.S. Preventive Task Force Services say it should be shared decision-making at 40 and then every other year starting at 50. American Cancer Society say annually 45 to 55 and then every other year. American College of Radiology says annually starting at 40. NCCN says the same, and the American College of Obstetrics and Gynecology, somewhere in between, and American College of Physicians basically says shared decision-making in your 40s and then every other year in 50. So it is really hard to know. And I think this actually makes a lot of people just say, hey, if they can't decide, I'm just not going to get one at all. And maybe if your risk was super low, that would be okay. But if your risk was pretty high, maybe the wrong people are choosing not to screen. So I think that's important. And I would say, I think one of the most exciting changes in breast cancer care has been that, we don't treat everybody the same because we know that all breast cancers aren't the same. And so maybe one size doesn't fit all when it comes to breast cancer screening either. And that's really what the Athena Breast Health Network was really trying to get at, because every woman has a different risk of developing breast cancer based on factors such as family history and genetics, breast density, age, race and ethnicity, other breast disease, lifestyle and exposures. And so maybe we should be trying to tailor or personalize these. And so there have been a lot of advances based on cancer prevention and our ability to do risk assessment. And, there have been legal safeguards in terms of patient rights. So there is, the Healthcare Portability Act says you can't be discriminated against on the basis of genetic predisposition. There's the GINA Act, which says that, again, something very similar. And the change in technology, and then, the other big change is that the Supreme Court ruled that you can't patent the genome, so that opened up the ability for many new companies to do genetic testing in a way that instead of it costing thousands of dollars, it could be down to hundreds or $100 or so, a couple $100 which is really in line with the mammogram, and it's a one-time test. And if genetics, even though not that many people have very high risk, knowing that is pretty important. And so of those 30% of people, what fraction of those people might actually have, unbeknownst to them, a higher risk that where they really should be prioritizing screening. And this is one of the questions that we want to ask. We don't know the answer, which is why we're doing the trial. But the first thing we want to do is say, is a personalized approach to screening better? And so we want to compare this to the annual, what a lot of people think is the gold standard. And is it just as safe? Does it reduce false alarms? I mean, people not going to come in quite as often for a recall because of something that's called abnormal on your mammogram or even a biopsy. Are women willing to accept something less than annual screening? And if we really focus on the people at the highest risk and offer them preventive interventions, if they really know their risk, will we do a better job of focusing in on the people at highest risk? And at the end of the day, are we doing a better job with the same resources? And it's not just the dollars that are spent on care, but it is the effort and the anxiety that people feel. So nobody loves going in for all this screening, but if you need it, we want to do it. And if you don't need as much, it's great to be able to reduce it. So that's the whole concept of not too much, not too little, but just, it's the Goldilocks principle, right? So, and, we're trying to impact, this larger population. There are 100 million women in the United States who are of the screening age for breast cancer. And what we want to do is, just get a fraction of those patients. If we can get 100,000 women to enroll nationwide, 40 to 74, and participate with us. Most women, as you can see, 65, 70% of people are screening anyway. If you take the next 5 years and participate with us, we can answer these questions and more, and we can continuously improve what we do. And that not only helps you, it helps your family members, helps your friends, and that's the whole idea. So we're really trying to look at this opportunity for personalized risk assessment, genetic testing, and high-risk counseling and risk reduction tools for the people at highest risk. And one thing I'd like to say about the Wisdom study is, once you join, you're really part of a movement. And I can't emphasize this enough. If when you join, you stay with us and you really help us learn, it's your study, you are the reason why we will be successful. If you don't stay in touch with us and don't tell us whether you're willing to follow the guideline, I mean, it doesn't matter what you do. We just want to know what you do. If we gave you a guideline to screen every other year and you say, well, I'm not going to do that, and you screened every year, we need to know that, because we need to know whether our recommendations are being followed. If something happens and you're getting a call back, or if something happens and you get diagnosed with cancer, we need to know about it, because we're trying to find out who gets what kind of cancer, and that's another really important contribution we can make. And that's, again, this study is as good as you make it. A lot of people say it can't be done, that we can't just rely to go directly to everyone and let them be the study. But I completely disagree, and I believe that the women who join the study really want an answer, are going to stay with us and be part of it and make it their study, and they're going to help us learn and learn themselves. So that's really important. So one of the issues is, what is randomization and what options do I have to participate? These are the questions people ask, and how long does the study go on and how much time does it take? Well, let's take each one of these as one at a time. I don't know if the video is, I see the black box, but I don't see the little video coming up. You want to share and show your video, Steph, while you're doing it? So let me tell you a little bit about randomization. So the scientific way we normally do studies is we don't give people an option to choose. We say, look, we're going to choose for you, and we're going to make it so that it's so that nobody knows which they're going to get ahead of time, and we randomly assign, just like by chance, you get assigned in one group or the other. And in many ways, that's a very important way to make sure we don't bias the results. However, we also know that there are some people who don't want to do it that way and really feel very strongly about one versus the other, so they're not going to participate if they can't choose. So that's one of the reasons why we're offering a choice, because we can learn different things, or certain things we learn from the randomized group, but there's certain things we can learn from the others. So I'm going to stop sharing for a second.
Did you try clicking the black box?
I did try clicking the black box.
Yeah.
So I think it just didn't show up for some reason. Okay, I'm going to stop sharing, and then Stephanie's going to show her screen and show this little quick video. Share, got it? And so there we go. Okay, go ahead and click it and show. I'm going to turn your sound on, and I'll turn mine off. Turn your sound on.
Wisdom study. We need your help. We'd like you to consider joining a clinical study to test which approach to women's breast screening is better. It's simple. We want to find out if all women need to get a mammogram every year, or if it's better to personalize how often women should be screened based on their individual risk. With your participation, we hope to end the confusion about how often to get a mammogram. Join the study today at wisdomstudy.org.
I'm going to unmute. Okay. And so, so those are your options. If you're not sure, it's great to let the study assign you. And remember, this is a 5-year study. We're just going to follow you for 5 years while you're part of it. It's so important that you answer once a year. We're going to send you a quick survey. It's actually really quick to start. It doesn't take very much time. It takes you about 15 minutes. You can do it on your phone. You can do it at home. You can do it from a library. You can do it any place you can get internet access. You can go to wisdomstudy.org. And you can either be randomized, or you can choose which arm you want to participate in. If you are already a participant and you're part of this, thank you so much. You are the reason why we will be able to go forward and make a difference here. But don't forget to log back in and complete your health surveys and tell us if you've had any changes to your health. And share the study with your friends and families, because it really makes, we need to get 100,000. We're at about 27,000. So a huge number of people have signed up, which is great, but we still have a long way to go. If you haven't joined the Wisdom Study and you're eligible, just visit wisdomstudy.org and sign up. And if you're not eligible because you've had breast cancer, or you just refuse to screen altogether, that's okay. But help us spread the word and make sure that we learn anyway, and share the website and join us on social media. So we want you to know that there's a huge team of people behind you that are really working hard to try and answer this question. And we have teams all over the country now that are working on this. We're really trying to reach out to diverse communities and make sure that we get representation from all ethnic and racial groups, because again, this is a study about women, for women, by women. We have lots of great men working on it too, but we want to make sure that we get it. We don't screen men routinely because their incidence of breast cancer isn't high enough. So this really is an important women's health initiative. So with that, I'm now going to turn over turn over the screen to Dr. Madlensky, who's going to talk to you about some of the genetic factors that we use to help understand risk. And again, we know about the role of genetics, but we don't know whether incorporating this routinely into screening is going to make a difference and whether we can do better. That's why we're asking the question. And again, if we can get an answer in 5 years, everyone who's participating, all of their friends, all their family members will be able to know better what to do. So with that, Lisa, I'm going to stop sharing my screen and I'm going to let you share your screen.
All right. Thank you very, very
You're
much.
on mute. Lisa, you're on mute.
Okay. So let me share my screen here. Okay, so thank you. I will also share with everyone watching today that I am a wisdom participant. And even though I am I guess you could say I'm a genetics geek. I've been working with and studying and practicing in genetics for 26 years. I elected to be randomized and not just choose the genetic testing personalized arm. Because that's how we get answers faster, is when people will be generous of themselves and choose to be randomized. So I encourage those of you who are comfortable with randomization, jump in the pool, the water's fine, everything's good. So some of the things—
I just wanted to say,
Yes.
I'm also a wisdom participant. So there you go. So the leadership of the study believes in the study and is participating.
Absolutely. We're not trying to rely on other people to get the answer for us. We want to participate in this as well. So as Dr. Esserman noted, there are a lot of different things that go into assessing any one individual woman's risk of getting breast cancer. And in the wisdom study, we incorporate all of these that are known to be risk factors for breast cancer. And interestingly, as new research comes out and identifies new things that may impact a woman's risk of getting breast cancer, we're trying to roll that into the study as it goes. So this is a really interesting opportunity to get as comprehensive a risk assessment as possible to really test out how that fares against annual mammograms. The two that I'm going to focus on today, which often get a lot of questions for people who are considering participating, is really about family history and genetics and the role that those play in terms of a woman's individual breast cancer risk. So one of the questions we wanted to throw out with a poll right off the bat is if any of you have a close relative, and by close relative, we're talking about a parent, a sibling, or a child. So normally that's a mom, a sister, a daughter who's had breast cancer, although if you've had a father or brother or son with breast cancer, obviously count that as well. So I'll give you a moment to answer your poll question. And we include not sure because a lot of women are adopted or they're not in contact with one side of their family or the other. And that actually takes an important part of a breast cancer risk assessment as well, whether we know how many women are in the family and whether or not they've had breast cancer. Okay. I'm not a singer in my part-time, so I will not sing the Jeopardy theme song. I'll just let the poll results go. Thank you. Okay. So this is actually very consistent with national studies as well. About 2/3 of women do not have a close relative. About 1/3 of women report a close relative. And given that this is a study looking at risk factors for breast cancer, this is actually a little bit higher than the national average. But one of the points I want to make here is that having a close relative with breast cancer is actually not that uncommon. Breast cancer is a relatively common disease. And so a lot of, thinking about risk is putting this all in the context of the fact that breast cancer is fairly common in the big picture. And a thing I want to point out in terms of personalization. So a lot of you have already heard or have already, been familiar with the idea that, a lot of general information that's out there about breast cancer risk will say something like, if you have a family history of breast cancer, your risk is increased. And if you look at the numbers that are very general, so for a woman in the left column who has no close relatives with breast cancer, the average 50-year-old woman, her probability of getting breast cancer over the next 5 years is about 1%. Her probability of getting breast cancers before her 60th birthday, by the time 10 years has passed, is about 2.5%. If that 50-year-old woman has either a mother or a sister who's had breast cancer, and that's all we know, that risk increases. So it goes from about 1% to close to 2% over 5 years, and about 2.5% to a little over 4% over 10 years. So in general, having a close relative does increase your risk. But if we break this down and look at it in a little bit more detail, what we can see is that it makes a difference, the age of that individual. So for example, if your close relative is a mother who got breast cancer at age 75, that's very close to the baseline level of risk. It doesn't increase your own personal risk by a whole lot. And that's because we know that in general, one of the biggest genetic risk factors or one of the biggest genetic indicators for breast cancer risk is whether your family members have had breast cancer before menopause or after menopause. Younger ages of breast cancer are more likely to have a genetic component to them. Not always, but they're more likely. If your one relative is your 40-year-old sister and she was diagnosed when she was 40, then that essentially doubles your risk. So this is a much stronger risk factor. So a lot of the risk assessment models that are out there just simply say, do you have a close relative with breast cancer, and really don't get at this personalized component of how old was that relative. And it makes a big difference. In general, when we think about family history and breast cancer, there are sort of 3 levels of hereditary or familial risk that we think about. The smallest piece of the pie, the smallest portion of the population, this is maybe 5% of all breast cancers, are due to a strong inherited cancer predisposition gene. So this is where the BRCA or BRCA genes would fall in. These are families where you typically see a really strong history of breast and ovarian cancer, and sometimes other cancers as well. There's also about maybe 15 to 20% of breast cancers that are called familial. These are families where there's sort of been a couple of cases of breast cancer. Maybe the age of diagnosis has been a little bit younger than average, but not excessively young. And genetic testing has been carried out, and we know that this is not because of a high-risk genetic finding that's running in the family. There could be a lot of other things going on, like shared environment and lifestyle, clusters of other types of genes that I'm going to talk about in a couple minutes. The vast majority of breast cancers are what we call sporadic, meaning it really is not related to any specific genetic risk factors. We don't see a strong family history, and the vast majority of these are hormone positive breast cancers, and they're happening after menopause. So that's the vast majority of breast cancers. When we look at what's going on in the wisdom study specifically, we're trying to capture all of these different types of genetic risk. So there's 3 main components to the genetic testing that we're doing as part of the wisdom study. In the personalized arm, the genetic testing that occurs as part of your personal risk assessment includes what I call traditional genetic testing. Most women think of the BRCA1 and BRCA2 genes when they think about this. So this is that small piece of the pie, hereditary risk. And these families, these results are relatively rare. What's a little bit more common, and what we're now testing for in the wisdom study, in addition to the BRCA genes, is 7 other genes that are related to having an elevated risk of breast cancer, though not as high as the BRCA genes. And this captures some hereditary risk families, but it also kind of now moves into the familial risk category, where the family histories are not as strong. And then there's a newer type of genetic testing that I'm going to walk you through. It's called a polygenic risk score. And that really gets more at a couple of the families where there's not one single gene that's explaining the breast cancers in the family. It's really looking at a wider range of weaker genetic factors. And it also explains a fair number of what we think of as sporadic breast cancer cases. So we're trying to cover the whole spectrum. And now I'm going to walk you through each of these three types of genetic testing. So the one that most women are familiar with is testing for the BRCA genes, BRCA1, BRCA2. And in the general population, about 1 in 400 to 1 in 800 women carry one of these mutations. So that's fairly rare. The exception is women who have Ashkenazi Jewish ancestry, where we know that 1 in 40 women actually carry one of these mutations. So it's much more common. And genetic testing is often recommended for any woman now of Ashkenazi Jewish ancestry, regardless of family history. That's a relatively new recommendation. But outside of the Ashkenazi Jewish population, the mutations are fairly rare. Typically, the cancers that we see in these families are premenopausal breast cancer. With BRCA1, we're more likely to see the triple negative type of breast cancer, which is a subtype that behaves more aggressively. We will often see ovarian cancers in these families, not uterine, not endometrial, not cervical cancers, but ovarian cancer specifically. And then with BRCA2 in particular, we'll often see maybe family members have had pancreatic cancer at an older age. And some of the men in the family will have had aggressive prostate cancers. In BRCA2, I should also note that men have a higher risk of getting breast cancer. One of the questions women often have when they are thinking about testing for these is, well, if I learn that I have a mutation and my risk is high, what do I do about it? The first order of business is to make sure that in order to manage that high risk of breast cancers, starting at age 25, so because the cancers happen at a younger age, we recommend starting with breast MRI, and then at age 30, adding on yearly mammograms. So any woman who tests positive who's over the age of 30, right off the bat, we want to make sure that they're getting mammograms and MRIs every year. Because of the high risk of ovarian cancer, where unfortunately we really don't have any useful screening tools like we do with breast cancer, there is a recommendation to have the ovaries removed at sometime between age 35 and 45, and where that happens is dependent on the gene, the family history, if a woman has completed her family that she desires. So there's a lot of variables that go into that decision. We wish there was a better option than simply surgery, but because we have no way to detect ovarian cancer at an early stage, that's really the only option there is. Conversely, with breast cancer risk, some women are very happy to just keep screening with their mammogram and their MRI, feeling confident that if something occurs, they're going to catch it early when it can be treated very successfully. That said, many women do choose to have elective mastectomies and reconstruction. Often these are women who have had incredibly strong family histories of breast cancer in their family. They may have lost many relatives at a very young age, and their thought is, you know what, the cycle stops here. I want to be as aggressive as I possibly can. So there's a range of options available, and we really recommend for women who test positive for one of these mutations that puts them at very high risk, that they meet with a genetic counselor, a high-risk breast clinic, a high-risk gynecologic oncology clinic, so that they can get the most up-to-date information about their options. And then this is time for a good quick poll question. So just curious about our participants and on the webinar today, have you ever had genetic testing for BRCA1 and BRCA2? Maybe you haven't, maybe you have, and it was through a healthcare provider, or you got it done through the Wisdom study. Maybe you ordered it yourself online. Maybe you're not sure if this testing has actually been done on you. So I'm curious to see what this looks like for our participants today.
Da 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 da.
I love it. Thank you, Laura.
Oh, you're very welcome.
All right. So let's see what our responses look like. So the majority have not. A few have through their healthcare provider. 10% have had BRCA testing through Wisdom. A couple of people ordered it online, and a couple are not sure. So that makes sense given the audience that's tuning in today for the webinar. You know, clearly you all have an interest in breast cancer risk, which is why you're here. Okay. So moving on to the next types of breast cancer genetic testing that we're doing in the Wisdom study. Of the 7 genes, in addition to the BRCA genes that we're testing, 4 of them are extraordinarily rare, like really, really rare, to the point where even if we get up to our goal of 100,000 participants, I expect that we'll have maybe fewer than 20 women altogether who have true positive genetic tests for these genes. That didn't already know that they had one. We've had a couple of people who've joined because they're interested in helping breast cancer research, and they already knew they had one of these. And we appreciate that. So these are very, very rare. The things that are actually coming up quite commonly, and the current estimate is about 1 in 100 women will have a mutation in one of these 3 genes. They're called ATM, PALB2, and CHEK2. And I think of these as sort of milder versions of the BRCA genes. They absolutely increase the risk of breast cancer, but not to the same extent that the BRCA genes do. And they do not necessarily increase the risk in a meaningful way of other types of cancers. So for example, as far as ovarian cancer risk goes, you know, currently, other than PALB2, we really don't recommend any action be taken to mitigate the risk of ovarian cancer. This is where we really get into doing a very personalized risk assessment for women. Just the fact that you have this mutation might increase your risk, but it also depends on, are you 40 years old? Are you 70 years old? What does your family history look like? Do you have a strong family history, or are there 20 women in your extended family who've all lived into their 80s and 90s and no one has ever had breast cancer? So this gets very complicated, but for most women who carry one of these mutations, we will recommend that you add a breast MRI onto your yearly mammogram screening so that you're getting both of those. In the Wisdom study, I want to point out that any woman who tests positive for any of these mutations, whether it's rare or a more common one, is notified by the study, and we have staff on the study that we call our breast health specialists. They're board certified genetic counselors, so they can walk you through any questions you have and refer you to a local cancer genetics clinic and specialty clinics to really get that personal care that you need. And then the third type of genetic testing that we're doing, just to wrap up my genetic section here, this is this newer type of genetic testing called a polygenic risk score. And polygenic means many genes. And if you think about it, we are not all clones of each other. We know that our DNA from person to person is not identical. We all have little variants that kind of make you the unique person that you are. The exception is identical twins who have the exact same DNA sequence, but otherwise there's variation throughout our entire genome, through all of our DNA. And that's normal, that's completely normal. What we've learned through large studies that really required international cooperation to kind of put all of their data together is that if you take, you know, we started out with maybe 50 of these little variations in the genome, then it was 100, then it was 200. Now we're up to over 300 of these little genetic variations in our genome. And you kind of map them out on an individual basis. It's sort of like saying you have a unique book, the novel or the biography of your life, and it's written in your genetic code. And how is your code spelled compared to everybody else? So we take that and add up the values in a kind of clever mathematical way of these 300 SNPs, which are single nucleotide polymorphisms, but really it's another way of saying those variations that we have in our genomes all over the place. We add that together and we call it a risk score. And we take the women who have the highest risk scores and we actually give them a higher risk assessment value than we would women who have average scores. And importantly, one thing we're learning that's very important is that we actually use different ways of calculating the score depending on your ancestry. So for example, a woman who is African American will get her score calculated in a different way than a woman who has Asian ancestry, and that'll be different compared to a woman who has Hispanic ancestry. So it's done a little bit differently because all of these variations come from our parents and our families and our ancestors. So the way we calculate it is slightly different. And what this is showing, I'm going to show you a little blow up of this. These different colored lines on the graph show if we take all the women who've had this polygenic risk score calculation and we divide them up into, so the light blue line at the bottom is the lowest 20%. The dark blue line at the top is the highest 20%. So this is similar to, the growth charts for head circumference and height and weight and everything that pediatricians use. But instead, it's taking what is the risk of breast cancer by age over a 10-year period. And you see this incredible pattern where if we map your score out and we assign you to one of these groups, it really is predictive of your level of breast cancer risk. So the other way I think of explaining this is that at the moment of conception, it's sort of like Mother Nature is dealing you your poker hand. What are the genes and what are the genetic variations that you got from your parents? For most people, you're going to get an average hand. There will be some high cards and some low cards, and it's not really going to move your risk by a whole lot. But for the women at the extreme ends, so if you get dealt that very rare high hand or that very rare low hand, it actually is enough for us to say, we think that you should change your screening, either less screening or more screening, depending on whether you ended up with a high or low hand. So just to finish up, some final notes on genetic testing, and this really applies more to the BRCA and the other types of genes, not the polygenic risk score. Most insurers have a set of criteria that they use to determine coverage. This is not yet a situation where anyone who wants it can access it through their insurers. The most accurate way for testing to happen in a family, if we think there is absolutely something hereditary going on, is for the relative with cancer to get tested first. That way we know, was that breast cancer caused by one of these genetic mutations? There's a lot of options for getting genetic testing now. There's sort of a menu of how many genes do you want to be tested for, and do you want to just limit it to breast cancer genes or consider other types of cancer? There are issues that a lot of patients and participants and people want to know about. So how certain are these results? The truth is you can get back results that are uncertain. A lot of people have questions about insurability, confidentiality and privacy with their genetic information. How do I share this information with my family, and which lab do I use? They all seem to be making claims, and is there one I should trust more than the other? And a plug for genetic counselors. We're here to help with answering all of those questions and get testing ordered for you. So again, that's just a summary of what we're offering in the Wisdom study, and I will stop sharing my screen.
Yeah, so I think one of the things that's important to know is anyone who has a mutation that comes with counseling and people who we consider to be really at elevated risk, we will actively reach out and counsel. So as Lisa said, coming with genetic counseling is important. So we have about 10 minutes left and we have lots and lots of questions. The good thing is that we're going to try and make this a monthly event so we'll try and get through as many questions as we can. And Lisa and I will commit to trying to give short answers so we can get to more questions. Allison, you're answering your questions, right?
Yes, I am. So thank you everyone so much for both sending questions ahead of time and also asking questions throughout the webinar. So I've tried to group them together in different categories. The first category is around imaging questions and mammography questions. So the first is about the best screening for women with dense breasts.
Oh, that is such a great question, and we do not have the answers. People who are extremely high risk, who also have very dense breast tissue, the best strategy appears to be MRI, and so people at highest risk for mutation carriers already get annual mammograms alternating with annual MRI. We are actually starting a study within the study for women with both dense breast tissue and really at highest risk to really look at different types of MRI. There's a new protocol for doing it very fast, and there's even a protocol for looking at how to do it without any contrast called diffusion-weighted imaging, and that's something that we hope the field will advance the field. So that's something that we're going to be incorporating into the study very shortly. You know, a lot of people say that you should get an ultrasound, but ultrasounds have a huge number of false positives, and it's not, if you really are at high risk and you really have extremely dense breasts, the MRI is clearly the better tool. So that's why we're trying to recommend that for people both at high risk with high density.
Great. And then another question around imaging for you, Laura. My doctor used to recommend annual mammograms, and recently they've told me I don't need to have them annually anymore. What is the right screening schedule?
Join the Wisdom Study and help us get the answer. How's that?
Wonderful. Yeah. Okay, so switching gears a little bit to questions around breast health. So one question is it normal if one breast is larger than the other? I know you had some guidance around what to look out for and what to contact your doctor about.
Yeah, it is. That is very normal. In fact, you know, people like Modigliani and painters who like exaggerate the features are just mimicking what's in nature. You know, one side of your face is often different from the other. You just often don't notice it. Most people have different shapes and size of their breasts, some more noticeable than others. The key difference is it different? You know, it's in one of the things that the UK has a really great campaign, you know your breasts, know your body, just be aware. Every woman should know you don't need to do a 30-minute exam. You just need to do a 1-minute exam once a month in the shower or some way when you're by yourself and just kind of know what your breasts feel like. Are they lumpy, bumpy most of the time? Is this kind of what they feel like? What you're really looking for is there's something really new that's different that wasn't there before. And that's it. And if they're lumpy, bumpy, the good time to examine yourselves is after your physician's examined you, so you kind of know what's there. But we really rely on women's history when they come in and say, this is new. That we really pay attention to because that matters.
Great. And Lisa, one question for you. So what is the biggest determining factor of breast cancer? Is it genetics or density or family history? Is there one that is a bigger determining factor than another?
This is where personalization is really important. If you are one of the rare women who carries a BRCA mutation, that outweighs every other risk factor we can come up with, right? It really genetically makes those breast cells more likely to turn from a normal cell into a cancer cell. Regardless of, you know, we don't really see that a lot of other factors modify it that much. They might, but not necessarily enough where we're going to make a different recommendation for you. Conversely, women who are at average risk, meaning they don't carry one of those, a BRCA mutation, maybe we've done genetic testing and we don't have any reason to think they have an underlying genetic susceptibility. All of these various risk factors actually combine and interact with each other. And there's not really one overriding risk factor. So a lot of women, if you check in for your mammogram every year, or you go to your primary care for your checkup and you fill in those questionnaires all the time. How old were you when you got your period for the first time? Have you ever taken hormone replacement therapy? how old were you when you had your first child? Those are all things that can move your risk up or down a little bit, but no, not one of those risk factors is going to bump it up or drop it down by a huge amount. So one of the things the Wisdom study is working on is what is the most accurate way to combine all of these risk factors and protective factors so that we can ultimately try and have like the best way of identifying who are the women at highest risk and who are the women at lowest risk, and give them guidance accordingly.
And it's such an interesting question too, Lisa. If someone has, for example, no risk factors, but they took hormone replacement therapy for 10 years, that would be their particular major risk factor. But maybe someone who's seriously suffering from hot flashes and can't sleep, and is looking to try and find out, can they take something if every other risk factor was really low? Is estrogen only without progesterone is not so risky. So there's a lot of nuance to this. And it's, again, the more we can contribute in a meaningful way to what drives risk and how to prevent it and how to reduce it, and, the better off we'll be. I think another exciting thing is that, we have the opportunity to participate in prevention studies, especially our highest risk women. And there is, a study that hopefully will start on Duvet for people at high risk who have hot flashes and things like that. So lots of opportunities to improve. As I like to say, we should always be thinking we can do things better tomorrow than we do it today.
So Laura, just to follow up on that answer, so one question that came in also was about recent info on hormone replacement therapy and breast cancer, and is there more risk or benefit if a woman is on hormone replacement therapy?
If you are on combined hormone replacement therapy, you definitely have increased your risk. There's just no question about that. I think that's been definitively answered. And that the longer you're on it, the more your risk, and it takes a little while for that risk to go away. I think what people may be referring to is the notion, if you are on estrogen alone, that does not appear to elevate your risk of dying, in particular of breast cancer, whereas if you're on estrogen and progesterone, it does. And that's probably because progesterone in particular is something that really drives the growth of cells, particularly hormone positive breast cancer cells. So that's the nuance in the hormone replacement.
Okay.
We are looking, there are alternatives like basidoxifene. This is one of the, plus estrogen, this combination Duvet is something that's being tested as something to see if that's safer, and particularly in higher risk women.
Great. Okay, and then question for Lisa. What types of cancer are genetically related to breast cancer, and what genetic testing is available and useful for other types of cancer?
So the primary one we think about, and this is mostly because we've known about the BRCA genes for over 20 years now, so we have the most information about those two genes, is ovarian cancer. And one thing this is a good time to mention, when you're collecting family history information, a lot of times when, especially women in older generations where they didn't necessarily feel as comfortable talking about gynecologic cancers, understanding the difference between ovarian, uterine, and cervical cancers. A lot of times we get women referred to us for a risk assessment for familial ovarian cancer. Turns out they had relatives with cervical cancer. There's no genetic risk. So really knowing whether it was ovarian cancer in a relative is probably one of the biggest indicators of a possible BRCA mutation. With some of the other genes that we now know a little bit more about, some of them seem to be just primarily related to breast cancer only and really not increasing the risk very much of other cancers. Other genes, for example, like the CHEK2 gene, which is a fairly common finding in women of European ancestry in particular, we know that individuals who have a mutation in that gene might have a slight increase in the risk of thyroid and colon cancers, and men may have a slight increase in the risk of prostate cancer. Now, when I say slight increase, it's not necessarily high enough that we suddenly jump in and do a whole bunch of extra medical screening for you. So that's where that personalized risk assessment comes into play. There are commercially available genetic tests that are sort of generic, and they're not targeting any one type of cancer. They target all common types of cancer. The yield of that testing is fairly low unless you have a family history that really looks like there's one of these strong genes running through your family tree.
Great, thanks so much, Lisa. And I know we're just past 1 o'clock, but we would like to stay on and answer more questions if people are interested in hearing some more. So we'll keep going, and please feel free to continue to listen in and send questions. But the next question is about the wisdom study, and what do I have to do and what steps do I have to do in order to participate? And also, is there any cost to participate?
The only cost is a little bit of your time and your interest and your willingness to be, part of the women who are willing to share their personal wisdom, right? That's the information about themselves. All you have to do is go to wisdomstudy.org and sign up. It's really quite simple. If you get stuck in the questions or you're concerned, you can always send us a question and someone will answer it, but it's pretty straightforward, right, Allison? You just have to answer a few questions about yourself. You have to choose whether you want to be randomized or choose an arm if you don't want to be randomized. If you are in the annual arm, we'll send you your assignment. You go get your screening. We check in with you. We'll send you updates and information every once in a while, and every year we send you a follow-up questionnaire. If you are in the personalized arm, we'll send you a spit kit just to your door from Color Genomics to get your genetics. Takes about 6 weeks to get through the process. The one piece of information that we have to get is the breast density information on your mammogram. So if you can get a copy of your mammogram and send it to us, that is the most efficient. If you can't, we'll try and go get it if we know where it came from. But I think that's really about it, right, Allison? Then we ask some other questions. We want to know how you're doing and whether, all the questions we're asking, whether this is upsetting or bothering or whether this is stressing you out, the information that we're giving you. And that's about it.
That's correct. And one important point to make is that you don't need to come in to any of the study sites in order to participate. You can sign up online. You'll continue to get your mammograms where you normally do with your local physicians and your local care team. We will just request the records from them so that we can understand your breast density and insert that into the risk calculation.
And if you wind up being someone at higher risk and we reach out to you, you can then take that information and share it with your primary provider or with someone who's really an expert in breast cancer prevention. If you don't have that, that's a service that we can make available. Now with video conference, that's actually one of the benefits of the COVID crisis is it's really forced everyone to make video visits possible, and those video visits can be from anywhere in the country, so we can make people available for consultations if people don't have someone locally that they can go to. But we can also share information with your primary care physicians if that's also another option for you.
Great. One other question about mammograms. There have been two questions. One is there a medical risk of annual mammograms, and are mammograms dangerous?
We don't really believe that mammograms are dangerous. The time when the breast tissue is in development is really from 15 to 32 or 35 at the latest, and we don't routinely use mammograms in those age periods. The amount of radiation that's used to do a mammogram is now about 1/10 of what it used to be. Your exposure of a mammogram is about the equivalent of taking an airplane flight from California to New York City, which people used to do pretty routinely. Maybe not so much anymore, but so it's a very, very low amount of exposure. I think the main risk from getting a mammogram is the risk of a false positive, about 25%, about 80% of the reasons when people are called back to get extra views or look more carefully, most of the time those are not because anything is wrong. And about 75% of the biopsies, or 3/4 of the biopsies, turn out to be benign as well. But that can be very anxiety provoking, and we know that can be very distressing for women. That's one of the reasons why we're trying to test, can we do less screening and people who are at lower risk, because the more you screen, the more you find, and the more times people come back. But we don't want to do less if someone's at higher risk, and doing it more frequently is of value. That's one of the questions we're trying to answer.
Great, sounds good. Let's see, and then a follow-up question around hormone replacement therapy, a clarification from a participant. So they've read that there's no evidence that short-term estrogen supplementation increases the likelihood of succumbing to breast cancer. Can you just clarify if maybe there's a difference in the type of hormone replacement therapy?
It is. So estrogen alone is not the culprit. It's the combined estrogen progesterone replacement. If you've had a hysterectomy and you no longer have a uterus, then then you would get estrogen alone. Really important that you not get progesterone. The reason progesterone is given is to make sure that people continue to shed the uterine lining, and so that you don't get an endometrial cancer. And that risk can be from estrogen alone, a very low percent, and usually it's, a low risk endometrial cancer. But the trade-off is if you're using progesterone, that can increase your risk of breast cancer. So what we need to do is do better, have different kind of combinations, and we're working on it actually. So, but estrogen alone does not come with the same risk as estrogen and progesterone.
Great. Okay. And then Lisa, we'll ask you this question. How will the data from the Wisdom study be used?
Oh my goodness, in so many ways. And in fact, one of the important things we do is, because this is a registered clinical trial, you can find it at clinicaltrials.gov. We're actually obligated to look at the data periodically to see if there's any early evidence that we've already answered the question. Usually when these types of studies are planned out, we calculate the number of people we'll need in order to answer the question accurately. Sometimes things happen where you can answer it a little bit earlier. Other times things happen and you need to extend the study a little bit longer. But so in addition to the main study questions that Dr. Esserman answered, which is, if we go head to head and say just regular annual mammograms that everybody typically gets versus a personalized approach, do we still detect the same number of breast cancers that are treatable? That's our fundamental thing. But within that, we have a whole team of researchers that are interested in a lot of different aspects of breast cancer and breast cancer risk. I'm interested in the results of the genetic testing that's going on in the personalized arm. How often do we find mutations? Were they expected? Were they not expected? We have researchers who are asking questions about how accurately women are able to assess their own level of risk. Do they believe what we tell them when we give them this fancy schmancy risk assessment? There are researchers who are interested in following very carefully the subset of women who, while they're participating in Wisdom, will actually go on and develop a breast cancer. We're following those women very, very carefully. So there are so many data points that we can track and follow and learn from because of the size of the study, but also because of the willingness of participants to share that information with us.
And I think one of the most important things that I think we can contribute is who is at risk for what kind of cancer, because every cancer is not the same. Some cancers are really ultra low risk. It's like if you think about cancers as a bunch of criminals, some are shoplifters and some are murderers, right? And, you don't treat the shoplifter cancer the same as you would treat, the murderer cancer. And so, if you are at risk for a shoplifter cancer, which we now have the capacity to tell, that's something, you would have a different kind of screening. Then we want to also make sure that we do better at screening for these very aggressive high-risk cancers, which we're not so good at right now. And that's one of the things that we hope will come out of this. And that's one of the reasons why we want to contact everybody in the study, and figure out how to profile everybody's tumor. It's actually information that everybody should know anyway. And it's something we can provide, and it will really help us understand, the connection between the genetic factors and all the other combination of factors together to really try and find out who's the population most at risk for these aggressive cancers, and maybe give us some clues to really target prevention in a very different way.
Great. Well, with that, I think we will wrap up for today. There were some excellent questions. Thank you so much to the audience for contributing those questions. We do have those questions saved as well, so if there are others that we can follow up on after the webinar, we will do so. You can always reach us at our email and toll-free number. We'll send that along to everyone who's on this call. And again, if you are already part of the Wisdom Study, thank you so much for being part of it. We do appreciate your participation, and reminder to log back in to complete your surveys and share the study with your family and friends. And also, please help us spread the word. If there are other ways that you feel like you can help build awareness around the study through maybe an employer or a social group or whatever it may be, we really need everyone's help to try and get more women in the study and make this answer come to fruition a little more quickly. So thank you to everyone. Thank you to Dr. Esserman and Dr. Madlensky for your time today. And please be on the lookout for more of these webinars. We'll have different topics for each one. So the next one will hopefully help give some further information about breast cancer risk.
Yeah, we're going to try and do these once a month and pick a different topic every time. So thanks so much to all of you for joining in. Thanks again to everyone for being part of Wisdom and spreading the word. So let's get some better answers and move the field forward together. Thank you.
Yeah. Thanks, everyone. Have a great day.